Hi everyone. So this week we will study patient safety, quality and value. So let's look at the agenda. I'll start with the defining safety, quality and the related terminology such as near miss, unsafe actions. Then I will list the safety and quality factors involved in healthcare. Afterwards, I will discuss the reasons why EHR is essential to safety, quality and value. I will also explain the issues that the clinicians are facing when they are using the EHR and clinical decision support systems. And I will describe afterwards a specific electronic patient safety measurement system and EHR reporting systems. At the end, I'll describe the integrated clinical decision support system and we'll discuss that how we can improve the patient safety and quality with clinical decision support system and with a couple of videos and examples. All right, so before moving to the lecture, I suggest you to stop the video here and open this YouTube link. This YouTube link will tells you a story about a patient Noura, and this will help you to build up the background why the patient safety and quality matters, and why the medical errors is one of the leading cause. In fact, medical errors are third leading cause of deaths in the US every year. More than 70,000 patients they die because of the preventable deaths, and in those preventable deaths around 30% of the preventable deaths are because of the medical errors. And this video will nicely explain the importance of working on the medical errors issues and using technologies to reduce the medical errors. So when you are done with this video, then you can start looking at the slide, and this slide will explain the terminologies that we will use throughout this chapter. For example, how we can define the safety in the healthcare. We define the safety in healthcare as the minimization of the risk and occurrence of the patient harm event, like the minimizing the risk of the occurrence that could harm the patient. That This is how we define the safety. Now, what is meaning by harm? Harm mean an inappropriate or avoidable physical or any psychological injury to a patient or the caretakers of a patient or family member. Now, adverse event is a pretty common. I'm sure the people, those who are working in the healthcare, they know adverse event, overuse, underuse, and misuse. So we define the adverse events as an injury resulting from a medical intervention. Then all the adverse events that could be preventable through optimizing the organizational structure or using the any assisted technologies, we can say those are preventable adverse events. Then overuse, underuse, and misuse are more relating to the medications and the procedures. For example, overuse means widespread use of antibiotics for the viral infection, where we actually don't need antibiotics, and we are as a doctors, if the doctor suggests, or we as a patient take antibiotics, that considered to be the overuse of that. Same as underuse. For example, several screening mechanisms are available for the cancer screening. We have several ophthalmological activities. For example, we have the vaccines available, and if we don't use the vaccines, or we don't use any screening procedures, then we are basically underusing the available technology. And same as the misuse. Examples could be having a routine back pain and doctor suggesting for the MRI. We see these examples quite often. The going for the lab test, going for the unnecessary X-rays. These are all examples of the misuse of technology. Okay, now when we say about or talk about the medical errors, so the medical errors are a fact, and unfortunately, it's quite common in healthcare. Despite we have sophisticated hospitals available, we have well-trained clinicians available, still the medical errors occur, as you see in this example. And we cannot blame or we cannot say that medical errors are always be individual errors. It could be the errors of the protocol. It could be the errors of this communication. There are several factors involved into that. Technology, if we can properly use technology, definitely technology can help to streamline things, and by streamlining things, it could reduce the medical errors. But the peoples have, for example, like by using technology, it can help in improving the communication between physician and patients. It can help in improve the clinical decision support system, or if we can use the clinical decision support system, as we see the example of drug interaction and drug to allergy indications. And it also help the in decreasing the diagnostic type of errors. Unfortunately, technology that we use that also come with their own challenges that sometime leads to errors. For example, if the people are not well trained, older individuals, the doctors or the paramedics, those who are not tech savvy, they could make errors while typing the medications, while using the systems. But the if we compare with the technology or without technology, technologies are definitely assisting us. Though at this times the evidence that we have, as we see in the EHR and clinical decision support system lectures, we don't have many evidence to support the when we say many evidence to support, uh, here we discuss the evidence which are based on the larger cohorts, larger community, and also the evidence that been generated over the years. We do have the evidence from for 3 to 5 years, but we don't have the evidence for like a two decades evidence, or we don't have the evidence for 10 to 20 years, which require to say that confidently that the medical errors can be minimized with the help of technology. Now, if we can classify the medical errors, we can say there are three types of medical errors. For example, diagnostic type of medical errors are the errors that occur at the diagnosis stage. Then the errors that occur at the treatment stage, and there are some errors that could happen at the preventive stage. For example, at the prescription stage, maybe over prescription, under prescription, misprescription, this kind of errors we can say is the error, treatment type of error that could happen. Then suggesting delayed lab test, that could be an error that could, we can say it falls under the diagnostic type of errors. Then we have dispensing medication. Dispensing medications could fall under the treatment and could be under the preventive as well. However, if you see in general, it's an impression that the treatment types of errors are the largest category. In fact, the research shows that the diagnostic type of errors are the largest in number, are reported more than the treatment type of error. The diagnostic types of errors could be because of the missed, wrong, or the delayed diagnosis. and are more likely be happen in the outpatient setting. The errors, and other thing, if you have noticed that the term of defensive practicing, we use that when, especially it's quite common a practice in the US system, when the doctors know that the patient may require a dosage of high potency, and deliberately the doctor they choose to give a dose of low potency, or maybe choose go for the procedure which are less intense than, or less intense, but and the more intense procedure are with the full procedure, it may or could create an issue with the patient. So the defensive practice could save doctors from any lawsuits. That's our it's considered to be a safe practice on the doctor's end, but it could harm to the patient. On the other end, it might delay or could delay the procedures of the treatment. The medical errors, because of the overdiagnosis, they occur. For example, the people they come with a chest pain, and with have some diarrhea, and maybe the a not well trained doctor could predict that it could be like some early signs of the COVID, or could be any other disease. He could relate that and start treating by giving that certain medications, which could result on more harm than good to a patient. But the results, that the overall numbers, we don't have the sporting number at this time that could show that the overdiagnosis cause medical error. Now, the patient quality, when we talk about the patient quality or healthcare quality, the Institute of Medicine, IUM, divides, or you can say the has a six criteria or six goals to measure the healthcare quality. As you see that the quality uh, is a trait which is not quantifiable. To make it like quantifiable, to make it a measurable, they have the six aspirational goals. For example, they say the medical care, the healthcare quality is at a top level, is a quality or the good quality if the medical care is a safe, if the medical care is effective, if the medical care is an efficient, patient oriented, and equitable. If all the characteristics are met by a certain healthcare organization, then according to the IOM, they are at the highest level, or at the top level of the healthcare quality. Now, how we define the unsafe action and missed care in healthcare? Unsafe action are any adverse events that could happen uh, from any person involved in the healthcare process. For example, unsafe action that could harm to a person could be result in from the healthcare team negligence, could be a doctors with misdiagnose, overdiagnose, and could be the patient itself. Maybe patient start taking the prescribed drugs more than the defined, uh, and then the missed care define that any aspect of required care that is omitted either in part or in whole or delayed. That this is how we define the missed care. Now, the thing is, both the unsafe action, which is happened with the by any medical staff, and the missed care actions, both actions are not well documented and often try to be hid by the hospital management. Many of the of above go unreported. As they go unreported, therefore it's quite hard to create a policy and implement by or suggest a policy and then implement and enforce by that policy by the federal agencies. However, at this time, there are several programs I will show you in the next slides through which the government and semi-government organizations are helping to the hospitals to are assisting to the hospitals to report the events. Now, most near miss events are not reported and many are not even witnessed. There should be a system of volunteer report and it should be encouraged and it should not be blamed if anything happen. Hospital management should support to the doctors, and if anything happen from any end, the all the in the throughout the chain involved, like the pharmacist to doctors to the paramedics to the patient, this should be taken as a challenge and should work collaboratively to resolve the issue. Now, the issue is that even if these unsafe action and missed care, uh, if these actions are reported, these are reported after those things happened, not even during that that events are happened, unless uh, the events are that big that it will go into news. Therefore, we say that most safety systems are retrospective, and we need to move that to be a proactive. It should be proactive, as any kind of event happen that could result into an adverse event, or that could result into harm to a patient, or the people involved with the patient. It should be reported. Now, with the deployment or integration of the electronic health record EHR system, the overall expectations from the EHR systems are now quite high. It's true that the EHR systems have greatly helped us to the hospitals from moving from the paper-based records, which had a number of disadvantages. We already have discussed that in the HR chapter and clinical decision support chapter. Uh, but taking the EHR system, that it could improve the safety, quality, and value. At this time, we cannot say with full surety because the evidence are quite weak. Similar to the clinical decision support system, which are often now integrated with EHR system, the the people management, uh, they they expect that the clinical with the use of the clinical decision support system, it could reduce 100% of the medical errors. uh, as we see the examples, like with the clinical decision support system, we can easily get different alerts. It could give the alerts to a doctors, could give the alerts to the patient, to the pharmacist, to the people involved in the entire healthcare sector. But just relying on that and just believing that the clinical decision support system is the silver bullet um, is not a good idea. Is not a is a uh, is not a clinical decision system is not a complete solution at all. FDA at this time trying to regulate the softwares that we will use that for treatment and decision making. These softwares are growing, proliferations are high number, and but need to be controlled, need to be audited time to time. Several government organizations involved, with the patient safety and quality and value, they organize, they work with the different hospitals, they train the doctors, they train the paramedics. They support in developing, acquiring implementations of the system. They help in the training, organizing seminars and webinars. Organizations, notable organizations are HHS, Health and Human Services. Then we have organization AHRQ, which is the Agency of Healthcare Research and Quality. Then we have Center for Medicare and Medicaid. Uh, Now, these organizations are there, but it's the at the end, it's the responsibility of the hospitals. They must assemble, analyze, and clinical trends, and whatever is happening. If any adverse event is happening, they should create a culture uh, of self-reporting, voluntary reporting, and should not be penalized people because the medical errors are happen, and if and should go to a root cause of that. If someone is involving deliberately over there, then there should be a procedure for go for penalizing, but should not right away go for the process of penalizing. This practice discourages the overall reporting process. Then, if we already have looked some tools and technologies that could help in patient safety and quality. For example, we look the in CPOE, in the clinical decision support system, the module. With the help of CPOE, it improves the handwritten identification. It reduces the it reduces the prescription time to arrive to a pharmacy. It helps in reducing the errors with the similar names, and and also it helps in providing information about such as drug interaction. So the CPOE, we can say, uh, is a tool that could facilitate or reduce the medical errors and improve the patient safety and quality. Similar to CPOE, we have the tools like health information exchange. It's not a tool; it's just a practice. In the health information exchange, if we can share the patient data from the hospital one to a hospital two, like in a way that the other system would communicate with each other, and that could help us to compare the number of patients, those who are taking the certain drugs. Then we can compare from like the practice from the different region, and in that way it could help doctors to plan for better treatment. Then the technology is just like ADC, automated dispensing tech cabinets. These are the ATM-like machines, those who help in dispensing medicines. Then we have technologies just like the pharmacy dispensing robots. Then we have home-based cabinet, like for the people those who are like sick, paralyzed, or old people. They do home electronic medication management system that provides the home dispensing mechanism for the people those who cannot go to the pharmacy. Then we have the IV pumps, that these pumps, for example, the people those who take the insulins, so the pump, they can use that pump with the patch, and the time to time the pump can automatically release the insulin, and they don't need to take their injections manually. Then we have EMR. EMR is electronic records of the medications that is integrated with the EHR and pharmacy. So this is uh, part of the EHR, is a big part, and in the under the EHR we have the EMR, electronic medical record, and electronic medical record has all the information about the medications, procedures, treatment, and in the sub part of EMR is the EMR, and this part only holds the information about the medications. Now, another technologies that help I'm sure you are already familiar with this is barcoding. With the help of barcoding, you can just scan that with the barcoder scanner, and all the information, just like the about the drugs, it automatically be added into a system. And you see that the pharmacist, and if you are working over there, you don't need to enter that information manually, because entering manual information, free text information, create inconsistent information, redundant information, and that leads to the several issues in healthcare when we do for automated data analysis, especially. Now, another part where most medical errors happens, which need to be improved, is the medical reconciliation. What is medical reconciliation? It has been observed the when patient transfer or transit from hospital to hospital, from physician to physician, from floor to floor, uh, there is a need to be a continuity of care. What was their procedure of examination? What was their procedure of taking medication? So the information when they transfer from one hospital to another hospital is not very streamlined at this time. This need to be addressed, and for that, like the Joint Commission mandate, hospitals must be reconcile a list of patient medications, admission, transfer, and discharge. Also, there need to be a task, maybe a facilitated with the EHR. We have at this time, they have offices involved over there, and most of the time, this process is handled manually, but could be handled through the EHR system. Main problem is that if the EHR system is not compatible, as we have more than 75 different types of EHR system, different practices use different EHR system, and not all EHR systems are cross compatible. This could this could lead to this issue when the patient transfer from the hospital A uh, to a hospital B or C. Then transferring of all patient information electronically sometimes is not possible, and that could lead to some medical errors. Now, if we want to see the barriers to improve the patient safety through technologies, the first point is we need an organizational level support. Health system leadership must develop a strong culture of safety. If the leadership is not uh, if it is not realized by the leadership that how important the reducing the medical errors and how important is to introducing the technology, then we cannot uh, achieve our goals. Second thing is developing or deploying the new technology, training the people involved, that take time, money. So the cost of multiple sophisticated HIT system is considerable. Cost probably be shared with a different hospital, or the federal organization should support that. Third, error reporting should be voluntary and inadequate, and usually after the fact. This should be made proactive, not a retrospective. So the organizational level barriers, financial level barriers, and the error reporting procedure optimization. Now, as we are using the medical technology, just like EHR, clinical decision support system, and several subsystem in the clinical decision support system, the technology may reduce the medical errors but create the issues. We also discuss in clinical decision support system chapter, EHR system chapters. Sometimes the clinical decision support system give a lot of alerts, and that result into a fatigue. And for example, if a doctor is prescribing a medicine to a patient, and the system is saying do not prescribe that, and the doctor still prescribed that then, and if anything, any adverse event happened, the legality part is still not well addressed. Who will be responsible? Is the doctor or the system, or the EHR part, clinical decision support system, management? And so this need to be addressed, if we would like to use these healthcare IT technologies. Then issues with the infusion pump, issues with the hacking of electronic healthcare system, issue with the training involved of different medical systems, are still issues that could lead to medical errors and need to be addressed. So to conclude that, we can say patient safety continues to be an ongoing problem, as with the too many medical errors reported yearly. And some medical errors, we see that the minor medical errors, they are not they remains unreported, and because of that, it's very hard for federal agencies to create policies for that, or to highlight that, and to prepare some helping materials to avoid, to minimize such kind of medical errors. Multiple organizations are reporting safety data transparently to hopefully to support the change. Then there is a great expectations with the healthcare technologies that we have at this time, to improve the patient safety, quality, and value. Then we can say there is some evidence that clinical decision support system reduce the error, but studies overall mixed. And at the end, we can say the leadership must establish a culture of safety to effectively achieve the improvement in patient safety. That's all. Hope so you have learned something new with this lecture. Please watch this video, and also read the chapter. Let me know if you have any question. Thank you so much.